Good afternoon. It's an interesting conversation. It's always nice to have standards. Oftentimes we have a lot to choose from, which sort of defeats the purpose a little bit, I would say. So I want to talk about patient dose tracking, and I was asked to speak on this topic, and you notice there's a question mark there. And I think that my hope is at the end of my presentation, I've convinced some of you, or perhaps the majority of you, that this is in fact something that is very, very useful and very important for physicists. I think we're all aware that there's a lot of manufacturers now offering these tools, and there's been a lot of discussion about radiation risk. We've had in the previous session, actually the whole session devoted to that. I would argue that once you get down to about 100 millisieverts or lower, that the risk is assumed to be present. We assume it to be very small, and I also believe it to be unknowable. I don't think we're going to ever come to an understanding of that in the context of a patient who is needing a medical exposure, but perhaps we can do a lot better job of communicating the benefit. Nonetheless, I think it's important to note, and this study points it out, of Smith-Beidman, that when you look at the doses, and this is where the dose tracking can assist, the doses oftentimes are higher than actually reported, and they certainly are more variable. And that's the key point that I want to address today. It's the variability. It's the uncertainty of what the actual dose is. And let me talk a little bit about that. This is probably the poster child for variability. This is a young patient who received continuous CT exams because the operator wasn't convinced that an actual exposure, in fact, had taken place. I don't know if this is something you had read about or not, but the truth is this patient received 80-plus exposures, and they immediately developed a redness of the skin. So this poster child is actually a good example of how we need to avoid unnecessary exposure. Now, I'm going to use an analogy. You'll see several pictures of cars today. The quality control process at Toyota has in place that any of the workers can stop the line when a defect is identified. And so in the operating room, this concept has evolved into one where the physician stops and we do a procedural pause and we ask, are we operating on the left arm or the right arm? Because we want to get that right. And so it's where the person is that's closest to the product that actually affects quality. And for CT, when these accidents have taken place in the past in the US, we came out with the XA25, and the CT dose check came about. And so sure enough, you set this on your console for the CT, and if the dose is too high, it pops up, and you have to log in and identify the reason why you wish to continue, or perhaps you want to rethink about whether or not you want to give that radiation. So this is one example of a quality assurance approach that is real-time and in use. So there are some components or tenets of quality that are offered up by Deming. It is the belief that things can be improved. I think we'd all agree with that. We know that the process creates the variability. We need a blameless environment. People don't come to work to make mistakes. We're humans. I think Peter just mentioned that. And so we find ourselves making silly mistakes when we really don't want to. And people closest to the product are the ones who are most able to affect quality. And we know this, in fact, would be the CT technologist or the radiographer for CT and the physician for fluoroscopy. The inventor of Six Sigma, who really promulgated the use of quality in manufacturing process, was a physicist named Deming. He had a long career in business and government, and he worked with Japan post-World War II. Toyota, in the 1960s, started introducing automobiles in the US, and they were substantially lower cost than the American competitors. And it took Ford Motor Company 8 years to finally figure out that one of the reasons why they could offer that lower price was because they had tighter tolerances for the manufacturing of their transmissions. And so the cost to the company to provide a warranty was far less. And this was a piece of information that wasn't lost in the manufacturers in the United States. And so there was a rush towards trying to improve their quality. Motorola formalized this concept in the 1980s when pagers became very popular. And they recognized that no system is stable, and they came up with Six Sigma, indicating 3.4 defects out of 1 million. So you're really striving for very, very high quality. We're the beneficiaries of this process. When you buy an iPhone or any smartphone today, it almost always works, doesn't it? And that's because people have really gotten into the high quality manufacturing. This is my favorite slide of the talk. In the 1990s, Jack Welch, a very famous businessman who was then leader of General Electric, put out in his annual report his initial efforts at Six Sigma at General Electric, which actually was with X-ray tubes. They were trying to reduce the delivery time and shorten it to their customers. They spent millions and millions and millions of dollars to do that, only to find out that when they queried their customers, none of their customers really felt any difference. They still suffered from the variability of the delivery. And Jack Welch wrote in the annual report to all the stockholders, variation is evil in any customer touching process. So what is it that physicists measure? Traditionally, we look at the accuracy. And could I have a show of hands how many physicists we have here today? So it's a dominant group. So I know over there. So we measure the accuracy. We obsess, is the CTDI vol correct? Is the air kerma correct? Can we get that down within 20%? Can we get within 10%? Well, these devices where these individuals received aberrant exposures, in fact, had accurate air kermas and had accurate CTDI vols. What I would submit is that the dose tracking software is a new tool. It's not going to give us Monte Carlo calculations so that we can take the 10% down to 2%, but it can look at a group of individuals and recognize that it's reproducibility that is very much a problem as we try to get not just one patient or two patients, but we try to achieve Six Sigma in the delivery of patient for an optimum exposure. Once you do that, notice the red circle it's the number of individuals. We're looking at the fact that every single patient is important, and we want all of those to be within the reference range and ideally imaged. So here's the thought process with tracking dose. We assume a basic fundamental right of patients that they have to feel safe with X-ray exams and procedures. I think we'd be hard-pressed not to agree with that. We know for a fact that it's the process that creates the variability, the uncertainty of being safe. People closest to the product and the process are most able to affect quality, and we need to identify the tools that empower operators, the CT technologists, the radiographers, the physicians. So just as a background, we've been tracking doses for about 7 years. As I speak, we have 55 CTs and 35 interventional fluoroscopy systems, and between the two, this has been greatly aided by the fact that we have radiation dose structural report. In fact, it wouldn't be possible without it. So I'm going to give two examples, one for CT, one for fluoro. For CT, we found there was a lot of variability in protocol version control, centering the patient, and Z-axis coverage. So we look at a value streamline. This is the process engineers tell us this is the key thing for a starting point. After a clinician orders a CT, the radiologist selects the protocol to be used on the scanner. We know for a fact that there's wide range and variability that comes about when the radiologist picks this. And so this is an opportunity for best practice to make sure that we have a consistent level of indications for a particular type of exam. So leave that point behind for now and move on that a radiologist specifies a particular protocol which must be well documented, and hopefully it is this protocol that gets on the scanner. Because when the CT technologist then starts to perform the study, of course they want to make sure that they have the correct patient. We know about that. The correct exam, the exam that was ordered by the radiologist, which could be confused if the exam on the scanner isn't clearly marked as being the one that the physician is ordering. And of course, their responsibility, because they are the pilot of that airplane. They are the ones who have a big role in how much radiation dose the patient receives. In our facility, we've gone to putting a 5-digit number, although we're only showing 4 here, so that for each and every protocol that we have, we can identify that on the operator's console. Here is 6110 is an abdomen pelvis triphasic liver examination. So when that exam is picked, that we know that it's on the scanner, and then we can put this into our tracking system. This is our report, and so this is our listing of our various abdominal protocols. Each one has a number, and if I click on 6030, that's a routine abdomen pelvis. In this date range, I know that we did 793 patients, and the average dose among that group of patients was 12.2 milligram. We did have one patient that received a high value, and if it's over our evaluation level, we can look into that more. But the key point here, I would say, is the use of protocol numbers. We all have our LAN ID, right, when we have to talk to the IT department, and the number uniquely identifies us as an individual. We need numbers to uniquely identify protocols. This allows us to differentiate these by the number of body parts, the number of phases, the z-axis coverage, and we need to adopt the protocol change management now in preparation for the supplement that has already gone by, Supplement 121, that is the CT dose or CT protocol management tool. So as we go forward, this is a way for us to gain insights into how protocols are being used. For instance, this is one of the reports that we do. So there are, of course, defined protocols, maybe your protocol book or an e-protocol. There are prescribed and performed protocols. So we can validate that the protocols are correct on all the scanners. And then for protocols that are prescribed in our software, we can then compare them with the protocols that were actually performed. So we can start to look at any sources of variability in terms of a protocol delivery. So now we're back to where the technologist is going to give the correct dose. So here is a mock-up of a control panel for a General Electric CT scanner. Our standard is a lateral and AP radiograph. And so if I just take 2 seconds, I once gave a talk to a large number of CT techs, and I asked them very quickly, I said, what is the biggest complaint that you have in your reliability of performing your study? And they all said, gee, only if all the radiologists would do the same exam, my life would be so much better. And everybody was in agreement to that. And then I turned to them and I said, okay, how do you position the patient in the gantry? And I said, how many people use an AP radiograph? And half the group went up. And some people, how many people use a lateral radiograph? And some people put it up. Some people said, well, I just put them up and use the lasers. And I said, I tell you, a physicist would tell you, if I could have my choice, that we would all standardize and do it one way so that we could understand it. And so it just shows how we're all human. Everybody has a slightly different way of doing it. And if we can standardize on things, we get some of the variability out. So we take our lateral projection, and we notice immediately that that patient's a little bit low in the gantry, right? So wouldn't it be nice, you see that little line there, if we had a tool? This tool does not exist, but if we had it, we could know immediately that the patient's a little bit lower. And we all know that if you get the center of the anatomy in the center of the image, you're going to get a better quality image, right? And because the tube current modulation varies as a function of where the anatomy is located, you may also save some radiation dose. So we could, if we had it, have a new pop-up screen that says, do you really want to move that patient? And here's how much you need to move it. And so you could run into the room and raise the patient up a little bit. and achieve a better set of data for your tube current modulation. So we know that if the patient is too high, for instance, you end up with a magnification effect, and this is easily proved by putting a phantom in there and showing that. So you could end up with a 50% higher dose to the patient simply because the patient is off 5 centimeters from isocenter. So it's a very, very simple tool that would make our lives a lot more easily able to certify that the radiation dose is properly prescribed. Another variability is too much coverage. This is to be a CT colonography. You only need to see the colon on a CT colonography, so you don't have to extend the range of coverage up into the lungs. And so we developed a neural net tool that could look at differentiate excessive from non-excessive z-axis coverage, and you can use this with image processing so that when you perform the study, the scanner actually comes up with the suggested coverage to know exactly where the proper start and stop positions should be for acquiring your axial slices. Okay. So, in fact, Siemens has this available on their latest software release for their scanner, and it comes up using a suggested box that you do not have to accept. But it's a reminder to the technologist that, okay, you're just interested in the lungs on this particular CT. And so this is, I think, is the smart way to go. We're helping achieve quality and specific, patient-specific dose delivery. Nothing is perfect. We have a tool that looks and automatically calculates in our database and alerts to us any suggestions of over z-axis coverage, too much radiation. And this one came up that said that we had 95 centimeters of z-axis coverage, and I said, whoa, that's got to be a record. That's a really, really long length of a patient to be examined for a abdomen pelvis. And sure enough, this patient had a very large lesion that extended down below their knees and rightfully did receive a very extended z-axis coverage. So in the end, this is a cumulative graph where we have taken, this red graph is from 2010, and it shows 100% of all of our CTs in a cumulative distribution. And so somewhere around 50% was around 18 milligray, 19 milligray. And to get to 90% of our patients, we had to go up to about 40 milligray. And if we then look at the year of 2013, after denoising and reducing our KVP to majority of our patients, then we would have more. So you can see the advantage of doing that. Fluoroscopy, the same thing. We have higher doses in the 2010 range, and then we found variability with these areas. Our high exposure rate is indicated here. I would submit to you that if we measured these, we'd probably find them to be about 20% inaccurate. However, it's very easy to note that they got 15 pulses a second, and if you reduce that to 7.5, you would immediately cut the patient dose in half. And by the way, there's no filtration in the beam other than aluminum, so if you add 0.1 millimeter copper, you're going to knock that down another 40%. So those two things alone are going to reduce the exposure to that patient by 75%. I want to show you this tool. We know with the benefit of the radiation dose structured report, the location of all the detectors, the table, and the focal spot. So if you tap your foot on the pedal 400 times, we know that, and we know where the patient's skin is relative to the interventional reference point. So these are good geometry. And knowing good geometry is very, very helpful. So if we have bad geometry, then you know that the patient's skin dose is going to be elevated from what it could be. The trouble is, you don't want to wait until the end of the report to see that. We need a real-time tool for the table and detector positioning. Likewise, we can recapture in DICOM the single irradiation event that is of the longest duration. And if you have a 212-second period of time for one irradiation event, that means the foot is on the foot pedal for that length of time. I would think that the opportunity exists that the physician might have been otherwise engaged dealing with catheters and forgetting that they have their foot on the pedal. It would be so convenient to have it communicated that the fluoro event time is exceeding some period of time, just as an aid, as a reminder that they are going through a fairly long period of time. So you can see our before exposures, our after exposures are substantially reduced. And in the interest of time, I'm going to skip over the cumulative patient dose tracking. That's a complicated subject, and it's worthy of a full discussion in and of itself. If you let me skip with that. So in conclusion, then, I'm just going to say that patient dose tracking is must-have. There's no question mark there. It's totally above it, and that's especially true when coupled with aids for operators. Thank you.